Hello.
Hi. This is the Innocent. Are you ready to start?
Hello.
The Innocent Samoy as well. I think you can proceed.
Okay. Good afternoon. Hello.
Good afternoon.
I'm fine. Good afternoon, everybody.
Good afternoon.
I'm fine. May I take this opportunity to welcome all of you members, and we have sent our apologies for the technical faults, all what that happened. May I take this opportunity to welcome all members of AfroPHC East African chapter to our consultation meeting. Welcome all of you. Okay, my name is Innocent Somboy, a clinical officer and health system management specialist from Tanzania.
Yes.
Interim president of Tanzania Association of Clinical Officers and Clinical Assistants. Also, I'm representing Global Association of Clinical Officers and Physician Associates to the AfroPHC. May I take this opportunity to welcome all members and to introduce so that we can proceed with the following steps. Dr. Innocent Besige. Can you hear me? Over.
Yes. Good afternoon, everyone. I am Dr. Innocent Besige. I am a family physician and I'm a senior lecturer at the Makerere University here in Kampala, Uganda. And as many of you are aware, I am the president of the Afro-African Forum for Primary Health Care. Thank you very much. We are really looking forward to a fruitful discussion so that we move our policy document to the next level before the workshop occurs in late October. Thank you very much.
Thank you, Dr. Innocent Besige. May I take this opportunity to welcome Professor Shabir? Welcome, Professor Shabir.
Thank you. And I'm not going to do much except just be in the background. So welcome to all of you.
Okay, thank you. May I take this opportunity to welcome Jamie?
Hi, everyone. My name is Jamie Colity. I am a medical doctor from South Africa and part of the AfroPHC executive coordinating team. Thank you for having me here today.
Thank you very much. So may I take this opportunity also to welcome other members in the panel so that we can use few minutes, few seconds to introduce ourselves, then we can proceed with the following steps. Welcome. Lynette. Lynette, can you unmute your mic and say something to us? Danny.
Hello, everyone. I'm Dr. Dan Goto. I'm from Uganda, and I'm glad to be here. Thank you.
Thank you. You're welcome.
Go.
Elizabeth Opondo.
Good afternoon, everyone. My name is Elizabeth. As you've heard, I'm a pharmacist and work with a company that does health informatics. I'm glad to be here today.
Okay, thank you. Rachel.
Good afternoon. My name is Rachel Abalu from Kenya. I work for AmRef Health Africa. I'm really happy to be here today.
Okay, thank you. Rebecca, welcome.
Good afternoon. My name is Rebecca Cherop from Uganda. I am a mental health lived experience. Thank you.
Okay, Daniel Caso.
Hello, good afternoon. My name is Daniel Caso, a clinical officer in Kenya. Happy to be here. Thank you.
Thank you. Alexander. Maria Goretti. Jan Damu.
Good afternoon, everyone.
Good afternoon,
I'm
Maria
Mary Goretti from Kenya, a lecturer at the University of Nairobi. Thank you.
You're welcome. Jan Damu.
Thank you. I'm Jean Damour Nyanguru from Metsa, Rwanda.
Okay. Michael.
Hello, good morning. I am a general practitioner from Greece, Athens, Greece. I'm director in Health Center of Bari, and I am responsible for the Health Center of Kinshasa, of the Greek Orthodox Mission in Kinshasa. Thank you very much for your invitation.
Thank you. Rosie Gaire. Rosie Gaire. Can you unmute your mic, please? Okay, Alois Urasa.
Hello.
Hello.
Yes, thank you. My name is Alois Urasa. I'm a health laboratory scientist based in Moshi, Tanzania. It's my pleasure joining you. Thank you.
Thank you very much. Yvonne.
Good afternoon, everyone. My name is Yvonne Kyogora. I'm a mental health clinical officer, and thank you for having me today.
Thank you. Consolata.
Hi, everyone. I'm Consolata Trivia.
Voice, please.
Working in midwifery, lecturer, University of Embu, Kenya. Thank you.
Thank you. Penina.
Hi, everyone. My name is Penina Hisa, based in Kenya. I'm a health advocate. I'm representing People's Health Movement. Thank you.
Thank you. Roberti. Mugabe. Cynthia.
Yes, hi everyone. I'm Robert, Uganda Service. Nice to be here.
Okay. Anyone who have not yet introduced him or herself, can you take this opportunity, please? 1 minute.
Hello, my name is Gregory Bulak. I'm a medical doctor from Moshi, Kilimanjaro. It's a pleasure to be in this platform.
Thank you. Good luck. Alexander? I think we have finished. Okay. Thank you, all members. And let us move straight forward to our agenda. May I take this opportunity to welcome Professor Shabir so that he can give us some information about AfroPHC. Thank you. You're welcome, Professor Shabir.
Thank you very much. I'm going to not spend too much of time. I think many of you are very familiar with the AfroPHC, and I'm taking over just today for Mercy Wanjala. She has another engagement and asked me to just open the meeting. But in terms of AfroPHC, we started a long time ago, not a long time ago, literally about 18 months ago, formally, to have an organization. And what we have progressed to is to have, I think, a organization where we are seeing members of the primary health care team come together across Africa, and where they share the sentiment of having a common view on primary health care, a common vision, with the idea that we should be having African primary health care service delivery under universal health coverage that should be comprehensive, accessible, high quality, responsive to local needs, and in partnership with communities, and importantly, delivered by strong teamwork, training, and supportive supervision. So what are we going to do to make that vision happen? We want to bring together the leadership of all healthcare workers and other stakeholders at the coalface in African primary care, and to develop AfroPHC as the voice of the primary health care team, where we want to share resources and support each other in building the primary health care team for universal health coverage in Africa. I think we have been trying to do different things, and we've put it together into a set of strategic objectives that is on the website AfroPHC.org, and you can go to the About AfroPHC and see more. But I think it's really about, importantly, advocating on appropriate primary health care human resources and primary health care teamwork for UHC, and for which the second half of this meeting will be about, a document that we're crafting that we want to consult with everyone concerned, including you in this meeting, to say, is this position a useful one? And it includes, how do we make a socially accountable primary health care where communities feel a strong ownership? And we want to take this advocacy and community accountability, not just Africa-wide, but down to local and country level. So to do that, we've been trying to capacitate primary health care stakeholders in policy workshops, in management training, in clinical CPD meetings, and in other ways that we think possible. And we've also been trying to strengthen the research competencies amongst the members of the primary health care team. And we have been trying strongly to share information and communicate this with regular newsletters and other emails across. And we're trying to build the AfroPHC as a membership, as an organization. And we have succeeded considerably in that we have now well over 1,200 members from across 64 countries, but about 40 of the 54 countries in Africa. And that's actually quite a large footprint from members of the primary health care team across Africa. But we need to go further. We need to build up strong membership. This is one of the strategies, is to get these kind of regional chapters to encourage people to join AfroPHC. So I encourage you to go to the website AfroPHC.org and look at the Join AfroPHC and join us. At the moment, it is free for associate membership, but as we're proceeding, it will become a paid membership for you to vote. But otherwise, the rest of the benefits of AfroPHC will be very much available freely to anyone across Africa. And I mean, the kind of people that have come together in AfroPHC are nurses, doctors, public health practitioners, family physicians, pharmacists, managers, advocates, specialists, students, activists, NGO representatives, community health workers. You've got a number of them. I think that it is an extensive list, including up to one point of having a traditional healer. We expect everyone, to welcome everyone into this organization. You can also go to the website and see our president is Dr. Innocent Besije, who's chairing, co-facilitating today. Our vice presidents, Francoise Mwabufo from Cameroon. And then we have members of an executive board that stretch right across Africa from a range of disciplines, whether it is nursing, community medicine, family medicine, community health workers. So I think it's a very widespread of people. So I just want to say we also have a number of supporting organizations, including the People's Health Movement that was mentioned just now. But there are well over 30 organizations, both Africa-wide and global, that have come to support the idea of an African Forum for Primary Health Care. And we have made out of them an advisory board that we have been meeting, and where we've gained a considerable amount of guidance in meeting regularly, and have taken the organization quite far in that respect. So I think let me stop there. If you want any more information, please feel free to go to the website afrophc.org, look at the about and look at all the activities that are there. We're very keen for people to join AfroPHC, so please go do that. Once you join, you'll be able to join a Google group where we share a lot of very useful information. And of course, if you're there, you'll be able to get information on the various activities, whether it is CPD meetings, research meetings, training meetings on management, etc., etc. So I want to stop there and hand over back to you, Innocent. Thank you. I hope that people are happy to join AfroPHC, because one of our key objectives in these meetings is to encourage membership of AfroPHC. Hope that helps. Thank you.
Thank you, Professor Shabir, for your nice presentation. And may I welcome Dr. Innocent Besigye, if there is anything to add on top before I move to the next step.
Yeah, thank you very much, Innocent. I really don't have much to add, just thank Shabir for always being there to make sure that AfroPHC is moving forward. Maybe just to call upon the members, I am hopeful that each one of us has had some time to read through the document and again have a deep reflection on that document, what we think we like and what probably we don't like, that may need modification or more clarification, so that we really keep this policy document a living one, that will keep on evolving with the prevailing circumstances, and we really need to make it more understandable for the ordinary use, because in addition to using this document to convince governments, ministries of health, and other stakeholders, we really need to remember that for universal health coverage, the overall, I mean, the main beneficiary, or the person who really benefits, or whom we should be focusing on, is the person at the grassroots. And therefore, we really need to make this document in a language that will be understood by everyone, so that it becomes, its utility is much more wide. Thank you, members. We really need to get going, so that the next 1 hour or 1.5 hours remaining will be fruitful for us. Thank you very much. Over to you, back to Somboy Innocent.
Asante, Dr. Besigye. Thank you very much. Okay, may I welcome Jamie to proceed with the next step of review of our AfroPHC policy framework. Jamie?
Yes, let me just share my screen for us. Okay. And let me just open up to slideshow. Okay, use slideshow. Great. Is that clear? Can everyone see the presentation?
Yes.
Okay, perfect. So as I said in the introductions, I'm Jamie Colity. I'm one of the AfroPHC Executive Coordinating Team members. And I just wanted to present this PowerPoint presentation that we have on the AfroPHC's Call to Africa. And it's really got some of the key points that are within the policy document that we just like to highlight within this presentation. So here on the first page, we have our call to Africa is to join AfroPHC and build effective primary healthcare teams for universal health coverage in Africa. So just a bit of background, we want to heed the call of African health professionals, as well as recognize African challenges and opportunities, note the global primary health care milestones, And the key elements of this call are to train, recruit, and maintain a sufficient frontline PHC workforce, as well as support PHC with resources and build robust PHC systems. So this presentation, we will look at our calls under those headings of PHC workforce, PHC resources, and PHC systems. So looking under the primary healthcare workforce, we want to strengthen human resources for PHC, for which we call on Africa to build a larger, better trained PHC workforce with more opportunities, including educational, financial, and clinical opportunities, and greater resources to enable PHC and UHC, as well as to build the team with task sharing and supportive supervision. So we want to call on Africa to acknowledge the burden on all cadres in primary healthcare and embrace interdisciplinary teamwork with a mix of all health professionals using respectful task sharing and supportive supervision for achieving PHC and UHC in Africa. Furthermore, under the PHC workforce, we speak about building a distributed leadership, for which we call on Africa to embrace distributed leadership practices and education for it amongst all PHC workers and managers to achieve PHC and UHC in Africa. And to build clinical governance, we call on Africa to embrace the important role of postgraduate trained family doctors in decentralized primary care settings in order to support clinical governance, coordinated care, and efficient referrals to achieve PHC and UHC in Africa. Furthermore, under the PHC workforce, we want to professionalize community health workers, for which we call on Africa to standardize, professionalize, and decently remunerate community healthcare workers that are strongly integrated with the PHC team, and furthermore, to aspire to a target of 1 CHW per 1,000 persons by the year 2040 to achieve PHC and UHC in Africa. And to also manage human resources better, we call on Africa to clarify and harmonize PHC workforce nomenclature for the different categories and disciplines in PHC, and to then embark on labor market analyses in PHC, including public and private, and specific PHC human resource for health policies and strategic plans to scale up the PHC health workforce by the year 2025 in order to achieve PHC and UHC in Africa. Furthermore, under our PHC workforce, we want to develop human resources better, for which we call on Africa to implement a robust educational and credentialing infrastructure for developing a competent workforce that is dedicated to delivering comprehensive PHC services necessary to achieve UHC in Africa. Then under PHC resources, we want to view political and funding action for PHC as an investment, for which we call on Africa to regard health as an investment and to leverage political goodwill for action on PHC and UHC by defining PHC in budget terms, ring-fencing the financing of PHC, and committing to at least 2% of their GDP on PHC for universal health coverage in Africa. And we also want to fight for global solidarity action on PHC funding pools, for which we call on the world to re-examine global social solidarity on PHC and strengthen contributions to PHC for UHC in Africa as a priority, starting with high-income countries increasing donor aid to 2% of their health spend and donor aid funds allocating 30% to an African Union pool for integrated PHC and UHC in Africa by the year 2030. Furthermore, under PHC resources, we want to manage pooled funds with strategic purchasing, for which we call on Africa to work towards better funded single pools for UHC funding, prioritizing strategic purchasing for PHC with standard and transparent contracting of both public and private providers in empowered decentralized units of PHC for universal health coverage in Africa, as well as reform PHC payment with blended capitation. We call on Africa to embrace simple national contracting of PHC teams with mixed or blended capitation models, including capitation, fee-for-service, and performance payments to achieve holistic and responsive PHC and UHC in Africa. Now coming to PHC systems, we want to embrace the biopsychosocial spiritual approach for PHC, for which we call on Africa to embrace the discipline of family medicine with its biopsychosocial spiritual approach to care to achieving PHC and UHC in Africa that is personalized, comprehensive, continuous, and coordinated, and in line with global standards, as well as envision comprehensive person, family, and people-centered PHC. We call on Africa to embrace primary care, defined by the World Health Organization as an essential level of care that needs to be responsive, person, family, and people-centered, and covers the full spectrum of care within the paradigm of One Health for PHC and UHC in Africa. Also under PHC systems, we speak about health in all policies for robust PHC, for which we call on Africa to prioritize PHC as the foundation for universal health coverage, making health in all policies an integrating and developmental public health approach to decentralized government, strengthening the role of PHC facilities with flexible models of non-hierarchical interdisciplinary teams, and creating integrated care models of public health service delivery of PHC and UHC in Africa, as well as build quality in PHC, for which we call on Africa to embrace the culture of quality and patient safety with strong teamwork, and to measure and monitor performance to achieve quality PHC and UHC in Africa. Furthermore, under PHC systems, we want to build the district health system, for which we call on Africa to place their trust in their frontline PHC workers with decentralization of resources and the locus of control to bottom-up units of care, together with robust management functions to deliver an agreed-upon results and operational accountability to implement PHC and UHC in Africa, as well as to impanel defined populations to a defined team. We call on Africa to embrace the strategy of empanelment of a defined population and linking them to a defined, fully staffed and equipped PHC team as a foundational step to achieving PHC and UHC in Africa. We also want to develop community-orientated primary care for Africa, for which we call on Africa to embrace community-orientated primary care in community practices of 30,000 by the year 2025, and aspire to community practices of 10,000 for achieving PHC and UHC in Africa by the year 2040. The blueprint for rural and marginalized health, we call on Africa to embrace the blueprint for rural health and rural-proof all health policies to support rural and marginalized primary healthcare comprehensively, especially creating step-ladder entry requirements for educational institutions and rural or marginalized student immersion for the full PHC team to achieve PHC and UHC in Africa. And then furthermore, under PHC systems, we want innovative e-health that is patient and user-friendly, for which we call on Africa to embrace the variety of e-health solutions for PHC by ensuring that sustainable national e-health strategies are supported by accessible infrastructure, interoperability, and user-friendly designs that enable the PHC team and patients and populations to enhance quality and support new models of care in PHC and UHC in Africa. So in summary, we call on Africa to empower and build an effective PHC team to achieve PHC and UHC in Africa. We, as the African Forum for Primary Healthcare, commit to educating and empowering our members to support this goal in any way we can. Thank you so much. And I'd like to hand back over to Innocent so we can continue the discussion for today.
Thank you, Jamia, for your nice presentation. I think all of us have heard what you have presented to us. And may I take this opportunity to welcome again Dr. Besigye to lead us on the discussion session.
Yeah, thank you very much, Innocent. I think, thank you very much again, Yami, for the brief but concise presentation and the synthesis of the policy document. And I think it will be somehow structured. I think would request to use two methods. One, I think the participants, you can raise up your hand, and also you can use the chat box so that we really get as much feedback from you as possible. So let's have now an open discussion. What is it that we like on this policy document? So we start with the good things that are in there, and then we can start to proceed.
I think you can raise up your hands, then we can allow you to give us your views.
I see Elizabeth, you're welcome. You can unmute and make your comment.
Thank you. I think what I like about the document is the fact that we're building in quality from the beginning and the metrics that will help us improve as we go along. So that for me, I feel is quite an important aspect. And hopefully we can tie that to even the training that we'll be offering so that even for the newer practitioners coming into the field, they'll already have that lens in place so that they can reflect on what they're doing and always be continuously improving.
Yeah, thank you very much, Elizabeth. Any other comment, members? I see we have two members. So Dan, if you can go first, then followed by Loba.
Thank you for the wonderful work done. However, when I was reading through, I felt that there's some items that could be collapsed together so that it doesn't look like something that is too long. I don't know, this is my reflection. Sometimes when you have so many points down the road, some internalization of those parts becomes a bit difficult for members. These are just my thoughts. If we could, as we move along, synthesize and collapse some of the items together.
So thank you very much, Danny. So I think the key point here to note is that probably we may be having some parts repeating themselves, and I think the message is that we need to look at the document again and see how we can condense the content for easy understanding by the readers or by the users. Yes, Robert, you can unmute and go on. Maybe if Danny can help us and probably highlight a few areas where he thinks we can collapse or condense the content, that would be helpful. So Danny, if you can have some time and review the document again and probably go online and make the comments, that will be helpful. Thank you very much. So Robert, you can go.
Thank you for the presentation. What I like about the document is the aspect of e-health, which is a very good component in all populations. We embraced it, and if you can push it, quality healthcare can reach all populations. Thank you.
Yeah, thank you very much, Robert. And I think it is, of course, the world is going digital, so I think we need the emphasis on e-health. Members, any other comments?
Dr. Besije, I
Yes,
think
please.
members, they have to look for in the chat box there. Professor Shabir has sent the link. So if anyone have any extra information, you can share to us via that link even after this meeting. You can proceed.
Yeah, I think that is quite helpful. And in the email, I think which invited us for this meeting, there is also the same link. So if you even after this meeting, you can go back to the email that invited you for this meeting. You will be able to find the link and then you make your comments. Yes, members, I don't see any comments or questions or clarifications being put into the chat box. So probably we can continue hearing from you. Any other participants with some comments?
Hi, Innocent.
Yes, Rachel, we can hear you well. Go on.
Yeah, thank you. Thanks for the document. And yeah, I really like the document. It's really very comprehensive. And I'm particularly very excited to see like the commitment, and they're getting very intentional with the professionalizing the community health workers, because this is something, and especially considering their role in primary healthcare in view of UHC. So this is an area that I'm really excited to see being re-emphasized in this document. I'll be happy to contribute further to that. Thank you.
Yeah, thank you very much. And I think, of course, one of the key questions that has disturbed people in the primary health care, the community health workers, because I think all of us know that there are different models being used in different parts of the world. So, and I think that's why the document is calling for some kind of professionalization and standardization. So that's quite a nice comment. I saw I think Michael was putting the thumb up. Or Michael, do you want to make any comment?
Yes, thank you very much again for your invitation. What I think the presentation was very interesting, and have very interesting initiatives, which there is what we need is to be more practical and more to say details about how we can manage the quality and all the other things that useful things that the presenter has put in her presentation. What we're trying to do in Kinshasa is to organize and function the health center with European standards. So what we do here in Greece, we will try to implement and transfer in this health care unit in Kinshasa. I think that what we are trying to do is very useful, very nice, but there is much road to do. Congratulations for this effort, and I wish you success. And I would like to join you in these meetings. I will try to write down some comments as Professor Sabiri recommended. I will try to write in the chat my thoughts, and I will use the link with the presentation to discuss with my colleagues who were trying to organize the Health Center of Kinshasa. Thank you very much, and we will be in touch. Thank you very much.
Yeah, thank you very much, Michael, particularly for committing to reviewing the document and making more detailed comments, and more so sharing it with your colleagues to have another other people's opinion on the document. And I think it's also important that you will bring into the document your European experience, and also what you have learned from the African context, and see what can actually work better, what lessons one can learn from the two contexts. And we are really looking forward to receiving those useful comments that will help develop the document further. So colleagues, please, I see Penina. Yes, you can unmute and make a comment, Penina.
Yes, thanks. The document is well articulated. It's only that we need to look into those terminologies so that it's kind of fields of the communities. Yeah. So looking into those terminologies, revisiting them, but also I've not seen the issue of. I don't know how to address it, but you can always ignore. But I feel that we need also to look into issue of brain drain. If we are talking about like the point one that we're talking about recruiting them, So how do we address this issue of brain drain? Because we've seen in African, setup that, after being well trained, then, you are being, taken somewhere else. So how do we address these issues? So it's something that we can ignore or we can take into this document. Yeah, thanks.
Yeah, thank you very much, Penina. I think that is an important area to look into. We can't really ignore it because if brain drain is not addressed using innovative means, we should actually be dealing with the bottomless pit. So I think it is important that the document should actually pronounce itself on that issue of brain drain. Thank you very much. So members, any further comments? I don't know, Innocent, whether you are taking cross look on the chat. Are we having anything from there?
Yeah, I'm looking on the chat. Maybe we can insist members to contribute more, because we're about 30, and you can see only few members have tried to give their views, but we want more views because we want to build our strong AfroPHC. So may I welcome other colleagues who can contribute more on our topic, please. Any member, please.
So it appears that we are not getting. Okay, I think Dan is saying is going to give a thorough dig into the document again and then see how to make further additions, which is quite good. I think that's really an avenue that is going to keep our document in a more active form. So I don't know if we any Shabir, you have any comment you want to make?
Yes,
and I would actually also request that, of course, I know there has been other chapter consultations that have been going on, and hopefully have been part of the process. If you can also probably give a summary of what the voices from other chapters so that we can see whether we are in line, and probably it can stimulate further thinking for us in the East African chapter. Welcome, Shabi.
Yes, thank you. I think I've been part of one. I think Jamie might be able to give you a bit of feedback on one or two others. I think generally there was a lot of favor for the document. I think I'm just trying to think of one issue that was raised. There's one issue once an issue raised about the importance of community participation to be much more strongly emphasized towards the end of the document. And I think that's something we need to consider. We do want to avoid, you might say, discipline-specific approaches or sort of sections, because it becomes quite challenging. But I think that oral health, mental health, rehabilitation, some of these areas of care need to be emphasized as well. I think that came out in some of the previous deliberations. I do think that what Danny is saying is true. We were very conscious of the fact that can we make the document easier to read, and in a way the nuances make it more complicated, because then it becomes too simplistic a document. So it's a constant battle. How do you keep the document easy to read, but keep all the nuances and important elements in the document? And I think that's an ongoing work, like you said, Innocent, that it'll have to evolve. We are going through a process over the next few weeks to have online consultations with a number of different stakeholders, including the chapters, and ending off in the October meeting where about 30 odd people from the advisory, executive board and advisory board and other key stakeholders come together and actually thrash out some of these. One of the key challenges is this, and I think this is something that we're going to have to look at in how do we make the document start from a story. And a simple story that I think we need to perhaps rethink the structure of the document. We try to keep it simple, but I think it needs a little bit more, where we say, you know, as primary health care workers who are giving care to people, we are challenged that the system is not supporting us to deliver the care in the best possible way that we think we can do it. And how do we think this can be changed? And yes, we do want human resources to be strengthened in primary health care, and there's this list of issues. And yes, we do want resources to be put in to the system. And it's almost, those two things are almost given. We want them up front. We've got some ideas about them. But I think that, to me, the real contribution that we need to emphasize is that the system needs to change. And the system change needs to be to move away from this very big organizational approach that we have, very bureaucratic approach in Africa, to saying, you know what, let's move away and use strategic purchasing to allow resources to flow right down to a defined team who takes care of a defined population. Now, you know, we don't have the indulgence like the rest of the world to have one GP to one family, but we can have one primary health care team to a family in a population, to give what is internationally good practice, to do that in Africa. So it needs us to convince people that, you know what, let's just give the chance for us to rethink the health system better, so that we can think of ways to do this. Now, some people look at the resource challenges in the country and they say, how can you actually achieve it? And I'd really, you know, I wish that I could have had more time to take people through, and maybe we will do it, take people through to the practice I worked in Soweto, where we have in fact created a practice that cares for 30,000 people, with a few nurse-doctor teamwork, community health worker teams that provide care very differently to the practice in public service, where the public service treats everybody like everywhere in Africa like a number. Whereas there, because the community health worker, the doctor, the nurse have been given support to work in the way they see things best, they have been able to deliver hugely better quality, but because they've been given the resources. And I think that to me is the crux of this document is, can the system support managers, people on the ground, people looking after team, the team itself, the resources and the ability to do what they need to do. And of course, everything else will flow, but that's the one big system change we need to see. So maybe that's something we need to make more clearer in the document, as Danny is saying, in the way of a story, and say that this is possible across Africa. So I don't know if Danny's point, raised was a useful one, but it's a very challenging one when you are sitting and crafting this document. And I hope it stirs up more debate and discussion in the group further. Thank you.
Yeah, thank you very much, Shabir, for the insightful comments. I see Danny is raising the hand again. Danny, can you unmute and go ahead?
Yes, I am really reflecting a little bit in my mind, and I'm looking at our intention, probably reaching out to different actors who are not within our network, say policymakers, governments, ministries of health, donors. In the current framing that we have, we seem to be a bit scattered so much, in a sense that it might be a bit difficult for such stakeholders who are not within us to quickly understand what we mean and what we want to achieve in a medium term, long term, short term kind of scenarios. My thinking is that if we could make the document also chronological, in a sense that we can give ourselves, these are the key priorities in the short term, key priorities in the mid-term, maybe in the long term, because some of the aspirations are in 2, 3, 4, 5, 10, 20 years. So I don't know, maybe that could now take us to the idea that we can say, okay, if you invest in these critical ones, this is how so much we can achieve our goals. And then incrementally we move forward. Maybe that can sort of help people to say, okay, if it's a big kind of intention, it becomes a wish list. Very expensive for anybody to take on and invest in. Governments are always afraid of investing and spending more money. You remember the 15% budget allocation that Africa has been discussing for the last 15, 20 years. It has not materialized. Now we are talking about 2%. Okay, where is the starting point? I hope I'm communicating. I don't know, this is just something raw in my mind.
Spot on, spot on. I think these comments are very helpful. Thanks, Danny.
Yes, thank you very much, Danny. I think the conversation is becoming much more lively, and I think by the end of the day, we shall have much more content to reflect on as we make the document better. I see, Yami, can you unmute and go on with your comment? And again, I think here, please, we would like also to hear the voices from the other chapters so that we see how we can use that information in a synergistic way for us to think better. Thank you very much. Please, Yami, go ahead.
Yes, thank you, Innocent. That's actually why I raised my hand. I just wanted to let the group know maybe a little bit of what we've been speaking about in the previous chapters. So I think we've had 3 chapter meetings now with different levels of engagement from each group. There have been groups where we've had larger numbers of people who have actually engaged with the documents, and we've had some groups or chapters where we had very few people who had actually gone through the document already. So each chapter's meetings had a different number or degree of involvement of the people who are actually on the call. But I think we've seen similar things coming through in each of the chapters that have been mentioned here today, such as I think everyone has really regarded the quality of the document quite highly. The document's really been commended for its content, and everyone's agreed that it's a really good, robust document. There's the issue of the formalization of community health workers that really comes up quite a lot. We actually, I don't think, have had someone suggest this need to make the document have a chronological features or emphasize what can be done first or what is more important, as what Danny was saying. But I definitely think this discussion is in line and in keeping with what the other chapters have said so far. In the other chapters, I think the chapters started off with talking about what the challenges were within the region and then moving on to the draft policy framework discussion. So there was a lot more emphasis on everyone discussing what the actual problems were within their region. But otherwise, I think that what has been mentioned here has been largely in line with what has been mentioned in the other meetings.
Yeah, thank you very much, Jamie, for that insight. At least we know that we are in line with what our colleagues from other parts of Africa are thinking. So members, can we have more comments, please? And I think, Innocent, if you don't have any more comments, then we can move to, I think, our next and last item.
Okay, thank you, Dr. Besigye. I think we can move on the next item. And our next agenda is to discuss on how to make AfroPHC forward. How can we move our AfroPHC? So I think it's again a discussion, or any member we can.
So I think, Innocent, one thing that I am thinking is that yes, we are discussing this at the level of AfroPHC, but I think if we can first reflect on what is happening in East Africa, and probably we look at what is working well, where the challenges, and how can we improve, and then we see how that would feed into the bigger agenda of AfroPHC. So I don't know what members think, but that's what I was thinking. Let's first of all reflect on how, on our current situation. I know, of course, we have different countries in East Africa. Each one of us has unique challenges, but there are also cross-cutting issues that face all of us. So, and I think, Innocent, you can sample from the participants from different countries. Sorry that you may put some of them on the spot, but I think it is one of the ways we can make sure that we are all inclusive for our region. Thank you very much.
Thank you, Dr. Besigye. And I think we can move forward, can proceed with the next step. Or Jamie, do you have anything to add maybe before we proceed? Jamie?
No, I have nothing else to add.
Okay, so we can move with the next item. Okay, thank you very much. So I think one of the things we can make, we know we are a member of East Africa, and we come from different countries. So maybe we can have views from members from different countries on how can we move our AfroPHC team. So may I welcome colleagues for your views or suggestions. And I think we have to think on how to build our task team from each region. because we come from different countries in East Africa. Welcome, members.
I see Danny's hand is up, so probably he can unmute and go on with it.
Yes.
Please tell us the country where you are from so that we can actually have an idea of the context
I'm
from
not
which
very
you are
far
talking.
away, Dr. Besje, from where you are. I'm not very far away. I'm seated, you know, Bazeo's place. I will not tell you that. Anyways.
I know the place, so don't worry.
Actually, I'm looking at him very closely here. One of the things I am really interested in this is that if we can grow country circles, because all the things that we've talked about have a regional context, but also have national context. And they can only be achieved if there is a very robust, aggressive national, you know, sort of a framework. And so that members, civil society within the country that have subscribed to the AfroPHC can have a platform where they can meet and say, okay, what are our key priorities based on this wonderful crafted document? Can we give ourselves for the next 3 years? What are we focusing on in our advocacy, in our, you know, implementation, in our lobbying, in our programs, in our, you know, all that dynamic, so that the AfroPHC becomes relevant to the people that we wish to support at the end of the day. Because primary health care is for the people, is really make people's lives better. So how do we now have a steering kind of arrangement within the countries that can even give us updates, can document things, publish or do all sorts of work around? I stop it at that, but I hope that really throws some light on that.
So thank you very much, Danny. So I think now it is clear that we need to bear in mind the country-specific issues as we think about developing and strengthening PHC. Yes, Robert, can you unmute and make your comment?
Actually, I will just add more voice on the previous speaker because as far as PHC is concerned, I'm from Uganda. Our challenges are a bit unique compared to other East African countries. I will take like an example for us to, let me take an example like on the workforce of Uganda, particularly nurses. Most nurses now are upgrading, but the uptake for them to really contribute effectively in primary health care is a big challenge. Example, if a graduate nurse completed today, getting Uganda's public service is still considering you having a degree as an advantage, as an added advantage for you to get a certain position to work in a given district or area. So I think we need to really focus on different challenges from different countries. Then another thing is that I think we need to do more of employing more, as we already joined this forum, we need to bring more members on board, different stakeholders who can really help us put this agenda forward. Thank you.
Thank you, Robert. Thank you for your nice contribution. We value your idea. Even Danny, we value your suggestion. Thank you very much. Any other member, please? Robert, you are still raising up your hands.
Let me put it down.
So I don't know whether we can hear for any colleague from Kenya, sure, if they can make a reflection, and so because we really want to hear from each country, and we see where we have cross-cutting issues, where we have uniqueness, and how we can leverage on that information to really move forward our vision and agenda.
Any member from Kenya? I think no one.
I see Wanjara is, I think, trying. If Wanjara, if you can unmute, please.
Hello.
Hello.
Yeah, we can hear you. Go.
Okay, I haven't been following effectively, but maybe at the moment I won't have any contribution. I'm a nurse, a midwife, kwa sababu I'm having network issues, so I'm not getting things clearly. Fully in PHC, I want to see it work and work for my community.
Thank you, Anjara.
Thank you. So can we have somebody from like Tanzania and maybe somebody you know better who can actually give us an idea of what is happening in TZ as far as the PHC is concerned?
Before we move away from Kenya, kindly.
Yes, please.
Sorry, yeah, so I just wanted to say that I think we have a national policy. We have a framework on primary healthcare. So what I would say, just in addition to the comments that Danny was making, and also the Maya, and I think Robert, I think what we need to do is to, in reflection of that policy, I really feel, first of all, what I think we need to do is to start by the representation, because I think it's very, we may not have the inclusion of all the other cadres or representation from the other workforce members. So what I would maybe think would be a good place to start from with our colleagues in Kenya is to perhaps just have a look at there's a national framework that you can have a look at, and then we also see some of the stipulations and see what is missing, and then in view of the country priorities, because I know we also have the national priorities in health that really need to come into consideration as we seek to strengthen primary healthcare. So for now, that's what I would say, but I know my colleagues also are here who can give some further suggestions. Back to you, Chair.
Yeah, thank you very much, Rachel, and I think that is quite insightful. So can we, I am just wondering if, for example, we can make reflections in our respective countries. For example, how are we, how is community participation happening? I think you had Shabil talking about empowerment where particular people, I mean, a PHC team takes responsibility of some defined communities. So for example, how is it happening in our respective countries? And what is it, which available mechanisms are there that we can engage? For example, is there a way how we can engage the East African community to help us develop and strengthen PHC in East Africa? Because sometimes at the country level, things may be a bit difficult. I want to give an example of how we do regulation of training institutions. As you are aware, there is a lot of political interference in the regulatory mechanisms. And if we are in Uganda and you have a problem, commonly, when it might not be easy for you to put your brother on the firing squad. But if we come as East Africans and we have a committee that is consisted of members from Kenya, Tanzania, Rwanda, Burundi, and they come, the Ugandans will keep quiet, and then the members of the committee from other countries actually take on the politically sensitive issues, because for them, in terms of politics, they don't have much to lose. So I'm just trying to think aloud. Is there a way how we can leverage on, for example, the existence of the East African community to strengthen the PHC? Over to you, members. So, Innocent, do you have anybody from Tanzania who can make a reflection?
Mr. Urasa, is it Mr. Urasa around or anybody from Tanzania? Anybody from Tanzania? Maybe I can add something because I'm a Tanzanian, so I can give you, yes, I can give you a reflection in our country. I like the previous member from Uganda. He told us something about nurses who are employed at the primary level, and once they upgrade their levels, they tend to move to other positions and leave their primary duties. So the same as in Tanzania, but in Tanzania, currently, among East African countries, Tanzania is the one of the countries which employ a larger numbers of clinical officers and the nurses at certificate level and the diploma levels. And most of them, they are working at primary levels. So there are a large number of, healthcare workers who are employed by the Ministry of Health to the primary levels. And the challenge is that people are trying to upgrade their levels of educations. They are going for training. Maybe you can, let's take an example. You can employ a nurse with a certificate, and he or she can decide to upgrade to up to a degree level. And from there, he or she doesn't want to work at primary healthcare levels. The same applies to doctors. We have many MDs. Currently, they are employed to the health centers and some of the dispensaries, few of them, but mostly at health centers and the district hospitals. But they refuse to go over there. If you ask them, they can tell you that they can't stay in a remote areas. But in those areas, there are people who are living over there. And there are people who need our help. There are people who need the primary health care services. So you can think, you can look, many people, they want to be paid much, and they don't want to stay at the village areas or at the remote areas. So most of healthcare workers currently, they are concentrating in town centers where they can do other things apart from, providing healthcare services. So this is a challenge to our country. Most of the peoples or most of the healthcare workers who are employed by the government, they don't want to work at the remote areas or at the villages. They want only to concentrate at the town centers. So I think something should be made so as to clear this mentality and to make these people more comfortable to work in those remote areas where there is a high need of the healthcare services. And currently, Minister of Health in Tanzania is trying much to make sure that the working environment of the workers, healthcare workers, are improved so that the healthcare workers can be comfortable with the environment and they can work more. Over to you, Innocent Besije.
Yes, thank you very much. I think that's an important reflection. And I think you notice that we all have issues of human resource in terms of training and appropriate deployment for effective or maximum performance. And I think those are those are the issues we have to keep grappling with. I think they said, Shabil, your hand is up. You can make a comment, then Danny will also follow suit. Shabil, can you?
Yes, thank you. Yes, thank you. I think that Danny actually raises something which I thought quite useful. I think for now, we should understand that a lot of the sort of clarity we need is exactly this document, which I think will help us to bring people, because I mean, in Africa, this is the first time people are coming from across Africa and actually saying, How do we deal with African primary health care? This otherwise was a decision in the WHO among government officials, and there have been really very few other forums like this, bringing the diversity of people. Perhaps AMREF has done something here and there. There have been other meetings, but I think as a consistent process, this is the first one I think we've got. So we must not underestimate the value of what we're doing, simply being here together and talking as we are with the diversity. So once we get this much stronger sort of shared vision, shared values around the framework, in the new year, I think what is being proposed by Danny is probably the way to do it, is to have, and this I think can be also supported by the AfroPHC, where as a group from the East African region, a task team made from the people in this meeting or key people from this group could then say, all right, let's have country chapter meetings where we can identify the priority issues and build up on that and assimilate it into a sort of the important things for the region. I do want to point out that WHO Afro is very keenly interested in working with AfroPHC, and they have indicated a openness to getting their country representatives to work with AfroPHC and to link up with governments. So I think there's a very useful opportunity, but it needs to be taken step by step. Us first understanding the framework and sharing that strongly, feeling strongly attached to one idea, a simple set of ideas. Then this group from the East Africa looks at country level meetings and regional level meetings over time, and then trying to get that happening in country. And I think we can do it all virtually, which is cheaper, but possible to bring on all sorts of key stakeholders in country around a conversation where we eventually hope there's an AfroPHC chapter in each country. But I think it needs we must be very careful to run too fast when we haven't learned how to crawl. And I think the crawling is about knowing each other and believing, subscribing to one set of values and a vision, and feeling comfortable with that. Because the risk is if we start setting off these country level discussions, we may land up with a very, very cross purposes kind of organization, and we might struggle. So I think this is, I think what yourself, Dr. Basich, have raised when we have discussed how do we unpack the AfroPHC across the continent. I think it's a similar value. Thanks.
Thank you, Professor Shabir. Thank you again. Any other member?
I think Danny had raised the hand, so Danny, you can unmute and go.
Yes, thank you so much, Dr. Innocent. Prof. Shabila, yes, I really support that, of strengthening, first of all, who we are, the values and what we stand for, and then create opportunities for people to learn and get to, immerse themselves in what we stand for and why we stand for it, and then progressively take on the different country contexts as they come on board. But I would ask probably if the steering group can create some form of timelines so that we know what are we working for in the short term, what are we working for in the medium term, so that the broader membership can understand. Even some regions might lag a little bit, some regions might move a bit faster, but there is an opportunity for one region to learn from another region, for one country to learn from another country. So that, yeah, if the framework is okay and it is cleared and approved by our leadership, then we can create key milestones, maybe in the beginning of next year. What are we seeing the other year? And then we progressively move. But I support your idea 100% because it's an organic way of growth, which has everyone coming on board. But in the meantime, if we can continue the promotion of AfroPHC within our country context. For instance, there are discussions that are happening around, all these things that we stand for. Members can still mention that yes, there is this other umbrella that is building and massive, we can still, tap into or relate to what it is the AfroPHC is standing for, even when the structures within countries have not started forming shape. So yeah, that is something that I think we can do individually in our organizations or individually in our capacities as people who subscribe to the AfroPHC.
Yeah, thank you very much, Danny. I think we are speaking the same language. Really, what you are saying is what you have been debating. I think what is remaining is really operationalizing the idea. I see we have about 25 minutes to the top of the hour, and we don't want to miss ideas from other East African countries. Is there anyone from Rwanda?
Hello?
Yes, can you go ahead, please?
Yes, I'm Jean Damour. I don't know if I have seen Rose. I don't know if she has something to say, but I can say something later.
Please go
In
ahead.
yes, in Rwanda we've developed healthcare to the community level that we, as primary healthcare facilities, district hospitals, health centers, we also have the post centers. Post centers equipped with nurses, and some health centers equipped with nurses, and even for this time we are now the government is locating there even doctors who have graduated from years back. So for those, as I said, the lower facilities health post, we are equipped with giving some services, small services, and health centers. Between health centers and district hospitals, now there are some health centers that have been equipped with some other additional services, either gynecological services, and with the doctors, specialists, and even some general practitioners. Those medicalized health centers minimize the level of transfer. Like the health centers used to transfer the patient to the district hospital immediately, but now in some areas they don't need to transfer them immediately to the district hospitals. Instead, they're transferred to those medicalized hospitals. Then this minimizes the number of transfers to the district hospitals. During going to the health workforce training, I talk about the medical doctors because I'm a medical student graduating soon. Now the undergraduate medical education has been named as the Department of Primary Healthcare, just to encourage and increase the awareness of primary healthcare in the future doctors. Like we have like a course of 4 years, first year, second year, fourth year. There is a course of social and community medicine where medical students at that level they study principles of primary healthcare. Later they go during the clerkship period, they have 1 month rotating in the communities to just identify the problems there, and then they propose the intervention projects, and then they present. That at the end, they facilitate know that medical students, which are the future healthcare professionals, are now prepared for primary healthcare, and they really understand that. So, Rwanda, that's the general picture I can give. And also going to the universal health coverage, you have this medical insurance that covers a lot of medical services, but from the previous time, there are some services that were not being covered by that medical insurance. But now there is a debate that those services, maybe not all of them, but some can be also incorporated in the package of someone who paid some little amount for medical insurance. So it's the general idea I can give. Going to the family physicians, in Rwanda we have I think there are 2 cohorts that was headed in 2012 and something. but they were banned. They are now, we no longer have that trainings. But last time I had a discussion with someone who was in that training of community and social and community medicine, how we can bring that back. So now we are in discussions with the Ministry of Health and the other partners, how we can bring that back. So maybe with the commitments of the AfroPHC and other stakeholders, we can bring that back not only in Rwanda and even in the other areas. I don't know if Rose can add something, or if you have another one from Rwanda can share something. I don't know. So thank you. This is very interesting. AfroPHC is bringing what we are really missing.
Yeah, thank you very much, Dean.
Can I say something about that?
Yes, Peter, go ahead, please.
Yeah, no, I'm very happy to hear what Jean brought up about Rwanda, because it's still very promising in Rwanda. And I'm very happy that that training, the undergraduate training in community-oriented primary care is happening there. And it probably has helped to save the enthusiasm about family medicine. And the former minister who abolished the family medicine training is gone. And there seems to be a new enthusiasm to start the training again. So I'm happy to hear that. And maybe we could ask AfroPHC how we can help in the lobby to get that training back.
That would be really more appreciated, because like if there was a training in 5 for the 2 cohorts, and now it's around 10 years without that training, now with the AfroPHC commitment and this process, we can increase the advocacy that you can have it back. Maybe it can't be easier, but it can be practical.
Yeah, thank you very much. I think everyone is hopeful that the family medicine training in Rwanda will start. And because we know that at the University of Rwanda, the undergraduate curriculum has a very strong component on the social medicine, which is really, which has a lot of content on the PhD. So all is not lost. So Loz, do you have any comment to add to make?
Dr. Besije?
Yes,
maybe I can remind other members on a message from Professor Shabir. They can look at the chat box there. Professor Shabir requesting members from East Africa who would like to volunteer to serve on AfroPHC East African Steering Committee. They should mention their names, the surname, email, and the WhatsApp number, and their country into the chat box there. So if anyone is interested to volunteer in the steering committee, he or she can nominate him or herself at the chat box there. Over.
Yeah, thank you very much. Of course, we really still need more people joining us. I was wondering whether Loz would like to make any comment. If not, do we have, I know, Michael, can you make any comment concerning what your experience or what you see or what you have learned from Congo as far as PhD is concerned? You know, Congo is a new member of the East African community, and we are really looking forward to making sure that we move along together. So Michael, over to you.
Yes, thank you very much again for your invitation. In the time of hearing you, I sent a mail to my colleagues where a scientific committee who the Archbishop of Kinshasa have ordered us responsible for the scientific organization of the Center of Kinshasa. One doctor lives in France. She's a psychiatrist. The other doctor is in Germany, specialized in tropical medicine, and the other is a lady, is a professor of nursing in Athens. And we have the last colleague is a technical technician for the lab. So as I said you before, what we are trying to do, because we are not living in Kinshasa, we cannot influence politically the leaders there. But what we will try to do is to transfer primary care European primary care values in this health center, who is going to work in we are going to have the license, the new from the local authorities in the next few months, and then gradually, because the funds is a very big problem, how to fund this this health center. So we will begin with with one doctor, one nurse, and one for secretary. And then we gradually, if we have the funds, we will go on. It will be a poverty where we will try to have low prices for the people, so they can afford the services. There, maybe we'll have donors of drugs, and so this is what we will try to do. This is a little effort. In the second plan, because we have the license of the local authorities for medical university, we will try to educate no doctors but no nurses for 18 months, as I had heard in a conference with Dr. Sabir have called me, that what we need in Africa and in Asia is health professional with a short education, 18 months education, so we can send them to the village to offer in coordination with the healers, as you say, the local healers, to offer the medical services. This is what we plan to do, with the blessing of the bishop. The new bishop's name is Theodosius, because the bishop before Nikiforos died a year ago from COVID-19. The successor is a new man. He tries to fulfill the dreams of Nikiforos. This is what we're trying to do, and all this is done in parallel with our other medical duties we have. But the connection with AfroPHC, which I am a member, Professor Sabir called me to take part in the elections who were done, I think, a year and a half before. So I took part in the election. So I'm a member of AfroPHC, and I feel it as an honor to be a member to the AfroPHC. But it is very useful for our effort, which I described in short. I received a proposal for the $1,000 award. So in this, in 1,000 words, we will send an article, and in this article we describe what I said. But this is the beginning, because when the health center will start to work, it will be the challenge for us. Thank you very much again.
Yeah, thank you very much, Michael. At least you have an idea of what is happening in DRC, and hopefully we shall continue working together to make things better. We haven't had any comment from Burundi. Is there anybody in this meeting who is from Burundi who would like to make a comment? If not, then I see Al-Mogila is here and is from Sudan. Al-Mogila, would you want to make any comment on the current situation of PHC in Sudan, looking at what is working well and what we can learn from there?
Thank you, Innocent. First of all, I'm very honored to be with you today, participating in this chapter, Eastern Africa. And really, I'm enjoying the discussion and sharing the experiences as I heard from Kenya, from Tanzania, from Congo, and from Rwanda so far. So I think we share the same issues regarding primary health care. The problem that's in Tanzania, or the doctors that are not retained at the primary health care, is the same in Sudan. Although we have some projects at some point in the time when we use an innovation in Jazeera State, I remember that the project of family medicine, which was covering all the villages in Jazeera State. Jazeera State is a central in Sudan, where doctors are incentivized not in terms of financial incentives, but also in training, because the government in Jazeera State offered the training free of charge for all those who need to be specialized in family medicine in this career. And really, at that time, we experienced dramatic stability in the workforce at the primary healthcare. For 2 years, we have availability of doctors in most of the villages, in most of the rural areas, in most of the centers, even in the towns in Jazeera State. And I think Prof. Shabir also visited or stood on this experience in Jazeera State, because the collaboration also was very, very nice between all the relevant sectors. For example, the University of Jazeera, Ministry of Health, National Health Insurance Fund at Jazeera State, and it was also one of the strong commitment for the governor of Jazeera State at that time. So the incentives, I mean, is not in terms of financial incentives, but also like training, offering them with laptops for the telemedicine. Things like this will really make breakthrough in the problem of unavailability of doctors in the rural areas. So my point is that we share the same problems in the region with all this. This is just an example of the also I think the problem of financing also it is shared among the region and also in Sudan, because we see that the primary care is underfunded, and the government at the local level as well as the state level or the federal level, they concentrate on the things that make show, political show. For example, building hospitals, concentrating on the secondary or tertiary care at the expense of primary care, primary health care. Although they know that if you invest well in primary health care, you will save a lot of resources. This is one of the problem. But I think the solution also will be most of what we said here regarding the problems of primary healthcare. I think all these are addressed in the policy document by AfroPHC. If we revise it well, we think that what is done so far address, if not all, most of the issues related to problems or challenges in primary healthcare in our region. Over. Thank you very much for it.
Yes, thank you very much, Al-Mogiran. It is always good to hear your experiences from Sudan. Members, we just have 5 minutes to the end of our meeting. I would, Innocent, I'm handing over back to you for anyone with any concluding remarks. I think we have had really from all areas within Eastern Africa. And I think we are not really getting any new information or new ideas. So if we can have some concluding remarks, and then we probably end our meeting in the next 5 minutes. Thank you. Unmute, please. You are still muted.
Okay. Thank you, Dr. Besije. This is a very fruitful discussion, and every one of us have enjoyed. And I have a comment from Dani Goto. He said that Burundi is a French-speaking, so they could be afraid to join this English-speaking platform. Let me answer Mr. Dani Goto. We have a translation here and the interpretation option, so we do accept a member from different countries, and I think there is a translation, so that's not a problem. So we encourage more Burundians to join the platform. And also, my key message: don't forget to invite other members to visit the AfroPHC website, and also to join the AfroPHC WhatsApp group for East African chapter. So we have to get more members, more views from different members within our region or within our East Africa community. Thank you very much, Dr. Innocent, again. So may I welcome any other comment from any other member before we wind up? Professor Shabir, maybe you can tell us just a few seconds.
No need for me to say anything, but thank you. It's been really very good to listen to everyone. And I think we are taking notes. Dr. Jamie Colotti has been taking minutes, and we're going to put all this together and try to ensure that we revise the document in preparation for the workshop in October. Thank you for all the time and energy being spent in it, and the very great volunteerism with so many people volunteering to be part of the steering committee. I think I'll trust that Dr. Besije and Mr. Somboy will pull this group together and build on this going forward. And we'll try and review that also when we are having our discussions as the executive board. Thank you very much.
Okay, I'm humbled and I'm grateful to you all. Let us build a strong AfroPHC team, and let us move our AfroPHC forward. Thank you very much. Thank you, everybody. You are welcome again for any other scheduled meeting in the next time. Thank you very much. Bye-bye.
Bye, everyone.
Bye-bye. Thank you very much. Bye-bye.
Bye-bye, everyone.
Bye, everyone.